So there are some pathological conditions which are precancers. The importance is that if we know about them, then we are ready for the cancer. We try to get rid of the cancer. We try to stop the cancer if we know the precancerous condition. And these conditions have different potentials. Some are very dangerous. Most of them can become cancer. Some are less dangerous, only occasionally. Some of these lesions can be GIT in the colon, large bowel. There are hyperplastic polyps. There are small growths in the mucosa of the large bowel. They have a low risk of cancer. They may be just 1 or 2% or even 0%. Very little chance of becoming cancer. Then in the middle are the colonic villus adenomas. There are occasionally some small growths in the colon, in the large bowel, which have finger-like processes. Villus means finger-like processes. So these adenomas can become cancer, and their risk is high. About half of them can become cancer if they are in large size, and depending on the size also. But if you see this name, the chances are that this can become cancer. There's higher risk. But still there's a condition in the large bowel called familial adenomatous polyposis. There are many, many polyps or growths in the large bowel. Polyposis, maybe thousands also, more than 100 polyps are formed. This is a familial condition, also called FAP. And almost all these patients can develop cancers or neoplasia, 100% chance risk of cancer, because there's a problem in the gene called APC gene. Adenomatous polyposis coli gene is faulty. There's a problem in this gene, and all these patients can become develop cancer of the large bowel. So these are just examples. Before that, we'll just quickly go through the revision of the terminologies. We have been doing this in the beginning of the first semester. What is atrophy? In atrophy, the normal cells, suppose these are the cuboidal cells, normal cells, they become flattened, they become small in size. This is atrophy. Then hypertrophy means those same 4 cells may become larger than the normal. It's hypertrophy. Then hyperplasia means they increase in the number, is hyperplasia. Metaplasia, when these columnar cells or cuboidal cells, they become squamous cells and multilayered. This is metaplasia. Squamous epithelium it is changed from the columnar to the squamous epithelium. And now the new term, now in terminology, is dysplasia. You have not read about this in the first semester. And what is dysplasia? These cells, these squamous cells, which are in proper way, they are low cuboidal at the bottom, columnar at the bottom, cuboidal in the middle, and the squamous at the top. So there's a proper orientation. But in dysplasia, this orientation is lost. There are irregular cells. Some are, even at the top, you don't see any squamous cells. Some are large, some are small. So this is called dysplasia. We'll see more in detail about it. But before that, let's have the attendance for the females. This is a question from the previous slide. Please reply in the chat box. In the comments, I give you 1 minute to please give your attendance. Only the females, please. What are the examples of cellular adaptations? A, apoptosis. B, atrophy. C, necrosis. D, neoplasia. Which of these 4? Thank you very much. So I'll give you 1 minute, then we'll continue with the next slide. Okay, we continue. And the answer, of course, is atrophy is the answer of this question. We continue with the next slide. So the term which was new in the previous slide was dysplasia. What is the definition of dysplasia? Dysplasia means disordered growth. This can occur in metaplasia and it can occur in hyperplasia also. It can occur at both places. We just saw that in the metaplasia, the squamous epithelium, which has formed from the columnar epithelium, this becomes disordered. Irregular cells come in the middle. There's loss of uniformity of the cells. There's a change in the nuclear uniformity. So you will see all these changes in the few pictures which will come now. So there's disorder of the growth of these cells. There's loss in the uniformity of the cells and nuclei. And there's loss of architectural orientation. What does that mean? It means that if you look at the squamous epithelium, they should be columnar in the lower level, polyhedral in the middle, and squamous at the top. This is the normal orientation. Architecture should be like this in a normal squamous epithelium, but in dysplasia, this is lost. You can see at the top also, you see these polyhedral irregular cells. In the middle also, you can see some squamous cells in the middle. And also there's change in the nuclei, change in the shape and size of the cells. So all these disordered growth is called dysplasia. When the dysplasia is severe, when it is severe and it is involving the full thickness of the epithelium, then we call it carcinoma in situ. Carcinoma in situ is also it called, some people pronounce it as carcinoma in situ or carcinoma in situ. So whatever you want to call, doesn't matter. So it is carcinoma in situ when the full thickness is showing the changes. All full thickness is showing the changes. We call it carcinoma in situ. This is a kind of severe dysplasia, is carcinoma in situ. Again, we'll go through the example of the respiratory tract. In the respiratory tract, the normal epithelium is columnar. This is the pseudostratified columnar epithelium of the bronchi in the respiratory tract. When a person smokes and there's chronic inflammation, it becomes, columnar epithelium becomes squamous epithelium. This is metaplasia, squamous metaplasia. And here you can see there are columnar cells at the bottom, polyhedral cell in the middle, and at the top, they are all squamous cells. This is a squamous metaplasia, which is proper. And again, this becomes a bit hypoplastic, but still in picture C, there is some darkness of the cells, but still you have the normal squamous epithelium, squamous metaplasia. But if you look at the lower three pictures, these D, E, and F, you see the cells are now becoming irregular. The nuclei are dark and they are large in size as compared to the cytoplasm. So there's irregularity. This is loss in the uniformity of the cells and the nuclei. Here in the middle, you see such big cells, big nuclei. Even mitotic figures can be seen in the high part. It's not visible clearly here. So all these features are dysplasia. But still at the top, you can see squamous epithelium. So it is slightly a moderate dysplasia. And as you go, it has become flat, but again, the changes can be seen through the full thickness. So this can be called carcinoma in situ. So there's loss of uniformity of the cells and nuclei. There's loss of architectural orientation. Now at the top, you can also see very less squamous cell, but you can see these polyhedral rounded cells at the top of the surface. Here you see squamous cells in the E picture, but here you don't see only one or two squamous cells. All the other cells are reaching at the top. So this is loss of architectural orientation. Cytologically, it's more easy to see, especially in the ladies of the West. We do these cytological pap smears in the cervical uterus, cervix uteri. We do these screening tests to detect cancer in these ladies before they completely become cancer. So this is the normal squamous cells in the cervix. If you look at the cytology, we take a cytological smear. This is how they look like. Very large area of cytoplasm and small nuclei which are rounded. They are uniform. These are the neutrophils, etc. But in dysplasia, see, very little cytoplasm, large nuclei, irregular nuclei, dark nuclei. So these are dysplastic cells. They are easily seen in the cytology preparations. In the histology, when you take a biopsy, you make sections, you look at after some time, you make slides. This is the green circle is the normal squamous epithelium. You see At the top, in the bottom, we have columnar and polyhedral cells. In the middle, again, polyhedral cells. At the top, squamous cells. And this area, the red circle, is the dysplastic. You see irregularities, dark nuclei, reaching at the top, no proper orientation. This is abnormal architecture and arrangement. This is dysplasia. And even severe is this. You can see very much severity. At the top also you see these dark cells. They are squamous, but still you see the abnormal nuclei. Here you see the mitosis. There's normally the mitosis has bipolar. There are two poles in the mitosis, but here you can see three poles, tripolar and quadripolar mitosis here. And this abnormal cells, all this is dysplastic cells reaching up to the top. So that's why we are calling it carcinoma in situ. So this is normal, green circle. This is dysplasia, moderate dysplasia in the red circle. And this picture on the right is showing carcinoma in situ. All these abnormalities you can identify in the biopsy specimen or in the histology specimen. You can better understand by the diagrams, of course. This is how the sequence occurs. Sequence means from the single change to full cancer. This is called sequencing. We have been giving those questions in the midterm also. The word sequence means how it happens. What happens first, then second, then third, like that. So you see only one cell has become on the left side, one cell with mutation. Because of that, there's hyperplasia here. In the second step, there's hyperplasia. In the third step, there's dysplasia. Some of the cells are now, the blue color cells are becoming abnormal. So this is dysplasia, which was from hyperplasia, it becomes dysplasia. And then these cells are reaching up to the top. We call it carcinoma in situ or in situ carcinoma. Both the terms can be used. From in situ carcinoma, that is, their abnormal cells are above the basement membrane. This white is the basement membrane, which is intact. It is not broken by these malignant cells. They are still intact. But invasive means it has broken down the basement membrane and gone into the deeper tissue. So in invasive carcinoma, the basement membrane has been broken down. It has been invaded by these malignant cells. Now these malignant cells are going into the blood vessel. The next sequence, which is not given here because we'll do it later on, is metastasis. Metastasis, when malignant cells, they go into the blood vessels or lymphatics to the other part of the body, and they start growing there like another growth. That is called metastasis, which we'll see in the later stage. So this is an important question we can ask you in sequence. What is the sequence of events in cancer production? First, there's just single cell mutation, then hyperplasia or metaplasia. Sometimes hyperplasia, sometimes metaplasia, then dysplasia, then carcinoma in situ, and then invasive carcinoma. This is the sequence of events. Another good diagram to understand. This is the normal 5 layers of epithelium. In hyperplasia, this becomes 8 to 10 layers. Then in this layer, they are still very much uniform, but in mild dysplasia, you see the cells are becoming irregular. They have lost their orientation. Some nuclei are small, some are large. So this is mild dysplasia, still only in the lower part. Upper part is okay. Then in carcinoma in situ or severe dysplasia, these changes are reaching up to the top. But still the basement membrane is intact. No cells are coming down. They're all going up. But invasive cancer, the malignant cells are going up as well as in the depth, in the sub-basement membrane is damaged and to the subepithelial tissue. So this is how you will understand. It's very clear how the changes, how the sequence occurs. Normal, then hyperplasia or metaplasia, then dysplasia, then carcinoma in situ, and then invasive cancer or carcinoma. Now we see very well-known precancerous condition. We may ask you them, so please remember them properly. Chronic atrophic gastritis in the stomach, chronic ulcerative colitis in the large bowel. Colitis means in the inflammation of the colon, which has ulcers in it. Solar keratosis of the skin. In the skin, this is also pre-malignant condition. Then leukoplakia, white patch, white plaque in the oral cavity, in the vulva, in the penis, anywhere where is squamous epithelium. It can become white in color, some area become white in color. This is a precancerous condition. We have to take the biopsy. We have to see the histology of that type, what type it is. Is it really cancer or just like that? We see that later now. In the female genital tract, it's an open tract, so there are a lot of precancerous condition. Most important, very common in the Western countries is the dysplasia of uterine cervix. The cervix of the uterus develops dysplasia in the squamous epithelium, later can become squamous cell carcinoma. This is because of the multiple partners these girls and ladies they have in the West, and that virus, the papilloma virus, produce these cancerous changes in them. So it is good to have, they develop these screening programs. They do the cytology of these ladies after 35 or 40 years. They regularly call them in the clinic, take the smears from the cervix, do the cytology slides, and see under the microscope for any dysplasia. And if there's any dysplasia, they do this a little bit of minor surgeries or burn that area. Otherwise, it can become squamous cell carcinoma. This is very common practice in the Western countries, Europe and Americas. Then occasionally, within the endometrium, within the uterus, there's endometrial hyperplasia. We have seen that this can be because of the hormones. There's hyperplasia, which can become carcinoma, adenocarcinoma. The glands in the endometrium become cancers. Then the placenta during pregnancy, the placenta is formed that can develop a benign tumor or a precancerous condition called high DTT form mole, which can become a cancer called choriocarcinoma. So you have to remember this. You may get some questions from that. And these patients, we know that these are precancerous condition, so we have to follow them by all these methods. I just now told you about cytology. We can also take endometrial biopsy. After the cytology is pap smear. They call it pap smear because the name of the stain is pepinoculose stain. So they regularly, just simple word, they call it pap smears. And the endometrial biopsy is done by a process called D&C, dilatation and curettage. They cure it out, they take out the endometrium and look it under the microscope. That is the endometrial biopsy by the method of D&C, dilatation and curettage. The hydatiform mole and the placenta is seen by this blood test. In this blood test, you see the beta human chorionic gonadotrophin levels. Beta HCG levels are seen to check whether there's any precancerous condition or not. Even after they remove the mole, they keep on doing this test so that suppose 1 or 2 cells are left behind, they can develop cancer. So it is very important to follow these patients by various methods. In the large bowel, the names are different. The basic thing is same. From the normal epithelium, there's hyperplasia. Then this is dysplasia in the colon is called adenoma. Adenoma in the colon is dysplastic growth, which can become carcinoma. It can go under the basement membrane and cause cancer. Don't worry about these difficult names at this stage, all these different names of the genes, etc., which cause these changes. So just remember, normal colon, 1 layer, it become hyperplastic or proliferative, multiple layers, this become adenoma. It is actually dysplasia. It becomes, but here it is called adenoma. And then this adenoma and dysplastic cells can go and become invasive carcinoma. Histologically, you can see the difference. Normal colon has these goblet cells. At the bottom, these are the normal cells. And here you don't see any goblet cells. These the nuclei are dark, blue in color, irregular. So this is the dysplastic glands, which can become cancer. It can become carcinoma, no glands, just single cells everywhere is carcinoma. In the upper GIT, we have done Barrett's esophagus. Whenever there's acidity, acid reflux from the stomach into the esophagus, the esophageal squamous epithelium becomes columnar. We call it metaplasia. This can become dysplasia, and this can become carcinoma in Barrett's esophagus. Similarly, in the atrophic gastritis, there's atrophy of the mucosa. Mucosa becomes atrophic. Plus, there's chronic inflammation. When there's chronic inflammation for a long time, chronic inflammation means an inflammation for a long time. This can become metaplastic, metaplasia, then dysplasia, and carcinoma. These are all precancerous conditions. Barrett's esophagus is more explained by this diagram. This is the normal squamous epithelium of the esophagus. By metaplasia, you see this become columnar. A lot of acidity when goes into from the stomach into the esophagus, it becomes columnar epithelium. It is columnar metaplasia. And if it remains for a long time, it becomes low-grade dysplasia. This is the picture of low-grade dysplasia. Up till this, it is reversible. You can, if treat properly, then it can go back to normal. But when it has become high-grade dysplasia, and then carcinoma in situ and invasive carcinoma, from here, there's no reversal. It becomes cancer from after this stage. And this is the gross picture of a cancer of the esophagus. This is the ulcer and growth of the esophagus. So this is Barrett's esophagus, which is also a pre-malignant condition or precancerous condition. Xeroderma pigmentosum. Xeroderma pigmentosum means, xeroderma means dry, derma means skin, and all this pigment, you can see this. This is a disease, a precancerous disease of the skin, precancerous. It is a genetic disease, autosomal recessive disease. AR means autosomal recessive disease. In this disease, this spreads through this autosomal method. You have done this in the first semester. There's mutation in the gene which repairs the DNA. The DNA repair, whenever there's cell division, some of the DNA can be damaged, so it is repaired by the body. But there some proteins are produced, some genes are present. It's a normal phenomenon to repair the DNA which is damaged by cell division. So if there's any mutation in these genes, DNA cannot be repaired, and the patients develop precancerous and cancerous condition. So this occurs in the children. Skin is very sensitive to ultraviolet light. The skin is atrophic. There's dryness of the skin. There's pigmentation of the skin. These young babies can develop cancers, skin cancers, like basal cell carcinoma. BCC means basal cell carcinoma. SCC means squamous cell carcinoma. MM means malignant melanoma. It was also called melanocarcinoma, but now they call it malignant melanoma. And this condition is very serious. Patients, they usually die early because of multiple cancers on the skin and also some neurological problems they develop. So they die very early, from 20 to 30 years of age. Now coming to your main topic, oral precancerous lesions. What are the precancerous lesions in the mouth, in the oral cavity? The two main we know are the leukoplakia and erythroplakia, and the two rare ones are the oral submucosal fibrosis and lichen planus. These are the less serious and rare condition, lichen planus and oral submucosal fibrosis. The main one, if you look, leukoplakia means white patch or white plaque. Erythroplakia means red patch. So these two are precancerous condition, and the risk factors occurs mostly in the patients above the age of 40, the persons who use tobacco, oral tobacco, alcohol, vitamin deficiency like vitamin A and B deficiency. Patients have improper tooth, sharp tooth, which continuously cause injury to the oral mucosa and then chronic inflammation, and then all these conditions can occur. In the viruses, we all know about HPV, the human papilloma virus. is a premalignant, is a virus that can cause cancers in the squamous epithelium, wherever, in the mouth or in any other parts. So this is a picture of different patches. This is a leukoplakia. In the picture B, you can see this white patch. And if you do the biopsy, it was only showing these plastic changes, nothing serious. Patient was okay. But there is another white patch here, another white and red patch and white patch. So that is called erythroleukoplakia. Erythroleukoplakia. So all these different names, you'll do more when you go to the 4th year in the special pathology of the oral pathology. And this is again red in color. We will call it erythroplakia. So more detail about leukoplakia. This is a premalignant condition. White plaque which cannot be easily rubbed off. This is the definition of leukoplakia: white plaque or patch which does not rub off easily. You cannot remove it easily, but just have to biopsy it. And then if you do the biopsy, if you do the histopathology, in 80% of the cases of leukoplakia, it is only hyperkeratosis. It's benign hyperkeratosis. In 12%, there may be some dysplasia. Only 3% of the cases may show in situ carcinoma or carcinoma in situ. In 5% of cases, there may be squamous cell carcinoma. These figures are very old. You will be more expert about these percentage in your practice. These are the figures given in the book, so don't worry about these figures. We won't ask you. We may ask you the definition of leukoplakia. That is why the star is there. Or the simple thing, we can ask you 80% hyperkeratosis is the simplest thing which we can ask from this slide. We will not exactly ask you these percentages. So this is a picture. See, this is hyperkeratosis. This, you see, thick layer of keratin is hyperkeratosis. This is the normal squamous epithelium at the bottom, no dysplasia in it, and only the top is keratin, hyperkeratosis. And this is normal, green circle, you already seen this picture, and this is dysplasia. So these changes can be seen in the leukoplakia, but carcinoma, invasive carcinoma is rare. Erythroplakia means red lesion or red patch or red plaque, which is less common but more serious than leukoplakia. What is erythroplakia? It's a macule, means a flat, velvety appearance. It has flat, macular means flat, velvety appearance. You know what is velvet? The girls might be knowing about what is velvet. Ever heard of makhmal? I was fancied because this in our country also, in our language also, we call it makhmal, but the Google told me that in Arabic it is also called makhmal. So, well, it's a cloth, type of cloth, velvety appearance of this lesion. Histopathologically, about half of these cases will have squamous cell carcinoma. They will have severe dysplasia or in situ in 40%. Only 10% of cases will have mild to moderate dysplasia. So erythroplakia is such a condition. Look at the diagram. This is the gross on the upper right corner. You can see this is the red patch. And these two histology slides, the right one is carcinoma in situ. All these malignant cells are above the basement membrane, reaching up to the surface, but not coming down. But in the invasive carcinoma, you see here, at the top are the dysplastic cells, but they are also going into the subepithelial tissue. They have broken the basement membrane, and you can see these malignant cells in the form of curl, pearls, and groups in the deeper tissue. So it is invasive squamous cell carcinoma. And the final slide is for the attendance of the males. I give you 1 minute